Welcome back, everyone. Our next talk deals with something we as medical practitioners encounter not only in our practice, but in our everyday lives. The limping child is a common source of worry for parents and a clinical dilemma seen by pediatricians and other healthcare professionals. Here to tell us how to deal with this dilemma today is the only female consultant orthopedic surgeon in the Philippine General Hospital. She graduated from the University of the Philippines College of Medicine in 2004 and went on to do her residency in the Philippine General Hospital, graduating in 2008. She went on to train in pediatric orthopedics in the Duchess of Kent Children's Hospital in Hong Kong and Korea University Medical Center, Guro Hospital in Seoul, Korea. She is the current head of the Elizarov Service of the Philippine General Hospital and is part of the faculty of the East Avenue Medical Center and the AFP Medical Center. Please welcome Dr. Cielo Balce.
Good afternoon. In diagnosing gait abnormalities in children, one may have an extensive and exhausting list of differentials. What we will present is how to logically clinch the diagnosis, but the details of management is beyond the scope of this webinar. Some conditions may not be mentioned as we will be sticking with the more common ones. First off is a very good history, which should elicit at least the presence or absence of pain, trauma, and systemic symptoms. The physical exam should focus in localizing the site of pathology, and the diagnostic exams and imaging should be able to confirm the primary working impression. Before we talk about limping, let's review the normal gait cycle. The stance phase, during which the foot is in contact with the ground, makes up 60% of the cycle. The swing phase, during which the foot is not in contact with the ground, makes up 40% of the cycle. One gait cycle is also known as a stride. Spatial variables are gait parameters measurable by distance and angles. The stride length is the distance between the heel strike of the same foot. The step length is the distance between the heel strike of one foot and the heel strike of the other. The step width or base of gait is the distance between the ankle joint centers. The foot progression angle is the angle between the line through the long axis of the foot and the line of walking. A negative foot progression angle is interpreted as in-toeing, and an excessively positive foot progression angle is interpreted as out-toeing. Temporal variables are parameters measurable by time, such as cadence or steps per minute, and speed or meters per second. At 1 to 3 years old, during the first independent ambulation, toddlers normally have short, asymmetric stride and step lengths, with a wide base of support, very high cadence, and slow speed. At this age, there is still no reciprocal arm swing, frequent falls, poor balance, and immature motor planning. Less than 50% of children at this age also demonstrate heel strike. They usually land with a flat foot. At 3 to 5 years old, the child should have more symmetric stride and step lengths, a narrower base of support, lower cadence, and faster speed. The child now walks with improved coordination and a reciprocal arm swing. At 6 to 7 years old, the child's gait and posture is similar to that of an adult. The stride and step lengths increase with increasing leg lengths. The cadence decreases with age, and the speed is more controlled. So what is a limp? It is any deviation from the normal developmental gait pattern. Limps may be dichotomized simply into the antalgic and non-antalgic varieties. An antalgic limp is characterized by pain and a shorter stance phase on the affected limb as the child avoids weight bearing on it. The presence of pain is important to note in history taking because this points to a more urgent if not emergent, diagnosis. Once you've established that the limp is antalgic, the next thing to ask is if there is a history of trauma or overuse. In an antalgic limp with no history of trauma, check if there are systemic symptoms. In an antalgic limp with no history of trauma and no systemic symptoms, localize the pain. In a patient complaining of knee, thigh, or hip pain, always rule out a hip pathology first, which may present with referred pain to the thigh or the knee. Typically, in a 6 to 8-year-old small active child with an antalgic limp, check the hip radiographs for any signs of osteonecrosis of the proximal femoral epiphysis or leg Calvi-Perthes disease. Important things to note: if the patient has LCPD or the age, stage, hip motion, and extrusion of the femoral head. In the typical age group, below 8 is rarely operative unless there's more than 20% extrusion. You need to be a little more aggressive as the child becomes older in the typical age group. Children who present atypically early, which is below 6, are also rarely operative, and those that present atypically late, which is above 12, salvage options may be employed. In a 10 to 16-year-old overweight adolescent with either an antalgic limp or a refusal to bear weight on the affected extremity, check the hip radiographs for a slipped capital femoral epiphysis. This is always operative, regardless of chronicity or severity, and the first line of treatment is in situ fixation with a single screw. If the hip findings are normal, the next areas to check are the knee and the foot. In patients with knee pain, no trauma, no systemic symptoms, no radiographic findings, with catching, popping, locking of the knee, a discoid meniscus may be the culprit, which may be confirmed via MRI or diagnostic arthroscopy. Surgical treatment depends on the type of discoid meniscus. Saucerization plus or minus repair may be necessary. In patients complaining of foot, leg, or knee pain with no trauma and no systemic symptoms, observe the foot while standing and walking, then localize where the pain is coming from. Usually, accessory bones like the accessory navicular cause irritation and inflammation to surrounding structures. If 4 to 6 months of conservative treatment has failed to control the symptoms, an excision of the accessory bone may be warranted. In patients with an antalgic limp, with no history of trauma, but with systemic symptoms, one should take radiographs of the affected area or surrounding areas, and also check for inflammatory markers. Patients with a painful limp with systemic symptoms may have bone, joint, or back pain. In patients with bone pain with high WBC, ESR, CRP, osteomyelitis should be considered. If confirmed in radiographs, combined surgical and medical management of infection must be employed. If the patient complains of constant or night pain and a progressively growing palpable mass, a tumor should be considered. Aside from radiographs, an MRI must be obtained, and a prompt referral to an orthopedic oncologist must be done for further management. Hematologic conditions may also present with constant or night pain. Hematologic profiling should be done, and a prompt referral to a hematologist is warranted. In kids presenting with joint pain, no history of trauma but with systemic symptoms and elevated inflammatory markers, infectious causes must be ruled out before considering a rheumatologic condition. In kids with an acutely irritable hip, septic arthritis, which is a true pediatric orthopedic emergency, must be differentiated from transient synovitis, which is a benign, self-limited condition. To help differentiate these two conditions, the Cocker criteria has 4 independent predictors, 5 including CRP in the modified version. Temperature more than 38.5 degrees Celsius, refusal to bear weight on the affected limb, ESR more than 40 millimeters per hour, and WBC more than 12,000 cells per cubic millimeter. The presence of only one predictor gives only a 3% chance of septic arthritis, and it's probably just transient synovitis, but still warrants close follow-ups and observation. The presence of 2 predictive factors already raises the possibility of septic arthritis to 40%, so a double setup of arthrocentesis plus or minus arthrotomy is necessary. 3 or 4 predictors give a 93 and 99% chance, respectively, of septic arthritis, so an outright arthrotomy is prudent. Another entity to differentiate septic arthritis with is tuberculous arthritis. Septic arthritis has a more acute course because of the aggressive enzymatic destruction of cartilage. Tuberculous arthritis has a more insidious course, and the cartilaginous destruction is mechanical due to the pannus formation. If an infection is completely ruled out and there's morning stiffness involving one or more joints with febrile episodes, juvenile idiopathic arthritis may be considered, and a referral to rheumatology is necessary. Patients with back pain, systemic symptoms, elevated inflammatory markers, and a gait abnormality should be worked up for POTS or tuberculous spondylitis. The limp may be caused by weakness from cord involvement. A painful hip with the back pain might also point to a psoas abscess. When the antalgic gait is accompanied with a history of trauma, investigate if it is caused by an acute injury or if it is due to chronic overuse. For these, radiographs usually point to the diagnosis. Fractures are managed either with casting or fixation, and overuse injuries like severus calcaneal apophysitis and Osgood-Schlatter tibial tubercle apophysitis are usually managed by physical therapy. Now let us go to the non-antalgic or painless limps. The Trendelenburg limp or lurch is caused by weak hip abductors and is commonly seen in patients with untreated developmental dysplasia of the hip or any hip condition where the greater trochanter rides up, rendering the hip abductors in a non-optimal position for contraction. Normally, the hip abductors level the pelvis during single leg stance. In a patient with weak hip abductors, when he is asked to stand on the side with a hip pathology, the pelvis drops to the contralateral side because of the inability of the hip abductors to contract normally. To compensate and prevent the body from falling contralaterally, the trunk bends toward the weak stance side. For patients with limb length discrepancy, circumduction of the longer limb during swing phase may be observed. For the shorter extremity, or if the contralateral knee is stiff, the contralateral foot compensates by tiptoeing, giving off a vaulting gait. Stoppage gait is seen when a patient has weakness of the foot dorsiflexors, which could be an early sign of a muscle dystrophy. Instead of a heel strike, they exhibit a toe strike on initial contact, and there is excessive hip and knee flexion to clear the foot off the ground during swing phase. An ankle foot orthosis can improve the gait by preventing the foot from dropping in these cases. The following are characteristic gait patterns in cerebral palsy. To understand how the ankle, the knee, and the hip behave when some areas have contractures, you have to think of it like a chain that will balance itself and keep the body from falling against gravity. An equinus gait is characterized by ankle plantar flexion and hip and knee extension on stance phase. It is usually caused by gastrocnemius spasticity or tightness. This is different from jump gait, where the stance extremity appears to be ready to jump with the hip and knee flexed and the ankle plantar flexed. This is often confused with the apparent equinus gait because the heel in apparent equinus appears to be raised from the floor, but when you look closer, the ankle is actually neutral. Crouch gait is seen in iatrogenically overlengthened or overweakened plantar flexors in the presence of quadriceps weakness. Without support from an orthosis, a ground reaction orthosis, or a knee ankle foot orthosis, the leg falls forward, causing the hip and knee to collapse into flexion. Now, scissoring is a crossing over of the thighs during ambulation and is observed when the adductors are very spastic or tight. Another common non-ontalgic childhood gait abnormality consulted for by the parents or grandparents is in-toeing, where the foot progression angle is negative. There are three areas you should examine: the hips, legs, and the feet. Physiologically increased femoral anteversion is common in the growing child. Femoral version is determined by the axis of the femoral neck against the axis of the transcondylar axis of the knee. This is 30 to 40 degrees at birth, then decreases to 8 to 15 degrees as the child approaches skeletal maturity. So it is fairly normal to have a bit of in-toeing below 10 years old, when the anteversion may still be physiologically high. To measure the clinical femoral anteversion, the patient should be prone with the knee flexed to 90 degrees. The examiner palpates for the greater trochanter as he internally rotates the hip until the trochanter is parallel to the examining table. The examiner then measures the angle using the long axis of the tibia. Increased femoral anteversion is rarely operative in the child with no neuromuscular problems. The child is discouraged to sit in a W position as this causes more weakness of the hip external rotators, which we want to strengthen to influence the femoral version to decrease as the child grows. Another cause of in-toeing may be tibial intorsion. This is clinically measured with the child prone or kneeling on a chair. The angle is formed by a line bisecting the thigh and a line bisecting the foot. A negative angle is normally seen in toddlers as their bones have not fully outgrown the influence of intrauterine positioning. By 5 to 8 years old, as the child matures in muscle posturing and gait, the intorsion should approach the normal 10 to 15 degrees in adults. The third area to check when rotationally profiling a child's lower extremity is the foot. The long axis of the foot from the heel should fall along the second web space. Foot adductus is more severe as the axis falls more laterally. If the adductus is flexible and manually correctable, only observation and stretching are employed. If the adductus is more rigid, serial weekly casting may be done. Rarely do these cases become operative. Dynamic deformities in the walking child may be treated with straight-last walking shoes. In summary, diagnosing the limping child can be challenging, but it may be made simpler if done in a systematic, logical manner. Important things in the history are the presence of pain, trauma, and systemic symptoms. The presence of any, if not all, of these three points to a more urgent, if not emergent, diagnosis. In localizing the area of pain, be aware of referred pain from adjacent areas, and it is prudent that these are also examined. Lastly, diagnostic exams are there for confirmation. Referral to other specialties may be necessary in some cases. Thank you.
what are some of the red flags that a physician or general practitioner should be looking out for in order to expedite the referral to the specialist?
The red flag should be pain, the presence of pain, a history of trauma, and fever. These things in the history point to a more urgent or emergent diagnosis and should be managed by an orthopedic surgeon as soon as possible.
How about the antalgic gaits, antalgic limps? No, so you have these children with chronic limps. They do not have a history of trauma. They don't really complain about any pain, but the limp is persistent. And the parents are worried. When would you when would you advise, or what kinds of limp would you advise a patient or the mother that he or she needs maybe surgery or further care by a specialist?
If the pain is actually chronic, it's usually not as emergent as an acute pain or an irritable limb. But these patients usually are athletes, right? So we want them to get back to their activities as soon as possible. And I guess the presence of pain, whether or not it's chronic, should warrant an orthopedic um, consult.
This is actually a common question I get when I have a mother or a parent come in with the children. Ano. In Tagalog, they're called sakang and piki, right? And I'm sure as a pediatric orthopedic surgeon, you encounter a lot of these. So maybe as a general guideline to all pediatricians and parents listening, when is sakang and piki normal, and when is it supposed to be something they should worry about?
A sakang child or a child with a xenovarum is usually normal below 2 year at below 2 years old. Um, the if the child is persist if the child has persisting xenovarum above 2 years old, then the parents should seek orthopedic consult. For the child with pique or genovalgum, um, it's actually physiologic um, at the 4-year-old up to the 6-year-old age group. At 4 years old, we can expect worsening of the genovalgum, but as the child approaches 6 or 7 years old, and the child's posture, muscle posturing, and gait um, approaches that of an adult, it should correct to the normal adult valgus.
So if are there things that a parent can do? For example, you know how parents do worry about children with deformities, especially for young girls, right? So is there anything that you can tell them to reassure them? Maybe is there something they can do to hasten correction, or is it something they just need to wait out?
Actually, it's something that parents should wait out. There's nothing wrong with letting the child do whatever he wants because it's part of the maturation process of of the muscle posturing as well as gait. So I won't really restrict activity in patients in the physiologic age groups of the genovarum and genovalgum.
So these actual deformities like genovarum and genovalgum, no, do they actually affect gait in terms of functionality?
In terms of function, or in terms of function, the genovarum would usually present with intowing. and the genovalgum
So genovarum is
intorsion.
piki.
Is genovarum is sakang.
Sakang. Okay.
Sakang, mga children with sakang deformity would also present with intowing and or in tibial intorsion. And those with genovalgum may also present with outtowing.
Another frequent question actually I get, I have an inordinately huge number of children who come to my clinic, even though I'm not a pediatric orthopedic surgeon. And one of the common questions that I'm asked by parents is what in the vernacular they call lampa. A child that of variable age, usually by 3 or 4 years old, and the parents always the parents notice that their child frequently stumbles. No, is this related to any of these conditions that you discussed this afternoon?
Usually, if the patient is stumbling, it could be an intowing or an outtowing, and we should inspect the feet, the ankles, the knees, and the hips as well.
So we seem to have run out of questions. So are there any last words from our speaker today, Dr. Cielo Balce?
It's actually the most important thing is the presence of pain. I cannot emphasize that. So if there's a painful limp, an urgent or emergent consult with an orthopedic surgeon should be done.
Okay, with those last words, thank you, Dr. Balce. Thank you both our speakers today, Dr. Carlo Emanuel Sumpaico, who discussed clubfoot with us today. I'm sure that they have enriched our knowledge about these two topics. As we bring this webinar to a close, we in the Department of Orthopedics of the UPPGH would like to thank all of you who have tuned in to our live stream and joined us on Facebook Live. As the webinars dissipate into the corners of the World Wide Web, we would like to invite you all to join us in real life, or as they say on Twitter, IRL, August 31 and September 1, 2018 at the Novotel Manila Araneta Center. See you all there. Thank you very much.